دكتور نور الدين من سوريا الشقيقة. هو طبعا دايركتور اي بي لاب واند هيد اوف الكتروفيزيولوجي ان جيرماني. ممكن تقول لنا السنتر؟ انا ما اعرفش اقرا الماني.
مünchen جلادباخ.
صعبة جدا.
معك حق.
اهلا وسهلا بيك وشكرا جزيلا.
احنا هنبدا الجلسات دي. اهلا بك يا دكتور نور، وشكرا دكتور انور على استمراريتك في العطاء في زماله الالكتروفيزيولوجي. واحنا الحلقات دي تحت عنوان اي بي كلاب. اي بي كلاب يعني ايه؟ يعني الكتروفيزيولوجي متقدم لطلبه الزماله سنه ثانيه وسنه ثالثه، غير مناسب لسنه اولى عشان ما يتعقدوش. الاي بي كلاب ده بنخش في الغميق في المواضيع اللي محتاجه نسمعها مره واثنين وثلاثه. كنت بتناقش انا والدكتور انور ان لو انت عندك حاله صعبه وعارف، طبعا انت عارف تدخلها، لو انت استمعت الى الفيديو مره واثنين وثلاثه ربنا هيفتح عليك وهتعرف تعملها. فالفيديوهات دي بتتسجل، والتسجيل ده عشان يكون لينا ذخيره نقدر ان احنا نستفاد بيها بقيه عمرنا. دكتور نور الدين اخ زميل وعزيز من المانيا، طبعا خاض جميع الامتحانات والاختبارات والجهاد في العلم لحد ما وصل لمرحله كبيره. هو رئيس اسم كهرباء القلب في المستشفى الصعبه اللي اسمها دي، وهو اخ عزيز تعرفت عليه مره ومرتين في اوروبا، وكان لي الشرف ان هو نبدا معا الاي بي كلاب. دكتور نور هيكلمنا على الفي تي as introduction and basic، وتو بي فولود بدكتور احمد طه، وهو الكتروفيسيولوجيست من جامعه الزقازيق، بس هو مقيم في السعوديه، وهيكمل ورا الدكتور نور بقيه اليوم. اتفضل يا دكتور نور.
ماشي. السلام عليكم جميعا، شكرا كثير على الدعوه. راح احكي البرزنتيشن بالانجليزي اذا ما في مشكله. So okay. Today we will talk about ablation strategies in patients with VT and VF. We have three lectures. Today it will be more theory, and the next two presentations we will make it in July, so it will be more practice, more practical cases. So this is my conflict of interest. So the agenda for today, so introduction, classifications of VTs, and then we will talk shortly about VT ablation in patients with structural heart disease, and with patients without structural heart disease, and with patients with ventricular fibrillation. So the most important question is, why do we need VT ablation in the ICD era? We have nowadays a lot of good ICD aggregates, and the question is, why do we need really VT ablation? So ICD is still the main therapy to prevent sudden cardiac death and to reduce total mortality, but ICD do not prevent occurrence of VT. Sudden cardiac death rate is still about 30% in ICD patients, and ICD shocks are associated with increased mortality. So we know the data from the very famous SCD HEFT trial, and we have seen that patients with appropriate and not appropriate ICD shocks, so appropriate and not appropriate ICD shocks were associated with higher mortality. So what is the concept of the VT ablation? The concept is not to treat the ICD shocks, but to avoid the shock. So when we talk about the VT, it's very important to make a very precise classification of the VT. So VTs can be classified according to duration. So we have the PVC, perimeter ventricular complexes, when we see isolated complexes in the ventricle. We talk about VT if we see 3 or more consecutive QRS complexes in the episode, so it should be 3 at least. we call the VT as sustained VT if the VT or if the episode lasts at least 30 seconds. And be aware, 30 seconds, not 30 beats. And not sustained if it terminates spontaneously within 30 seconds. VT can be classified also according to morphology of QRS complexes. So we have monomorphic VT. So we have similar QRS configuration from beat to beat. However, we can see some variability in QRS morphology, for example, at initiation or at termination. For example, fusion beats. We see sometimes multiple monomorphic VTs. It means we have more than one morphologically distinct monomorphic VT. So in every ECG, we have monomorphic VT with another morphology. Or we see more polymorphic VT. Polymorphic VT that has the QRS configuration is changing continuously, like in this case, in a patient with CPVT. A pleomorphic VT, it means a VT with at least one distinct QRS morphology during the same episode. So it means, so the pleomorphic VT, we see one monomorphic VT and it changed in the same episode to another monomorphic VT. And we have the ventricular flutter. It's a rapid VT, very rapid with sinusoidal QRS morphology. And ventricular fibrillation is a rapid ventricular arrhythmia with this very chaotic morphology. And also, VT can be classified according to clinical characteristics. We have the clinical VT. The clinical VT is the VT that is recorded in the 12-lead ECG, or maybe sometimes we have only the cycle length from the ICD record system. And of course, it's important for us, for the ablation, if the VT hemodynamically stable or unstable. And we talk about VT storm. If we have 3 or more separate episodes of sustained VT within 24 hours, each requiring termination by an intervention, for example, defibrillation or ATP or ICT shocks, for example. I would definitely recommend to read these 2 guidelines, 2015 and 2018, the expert consensus statement. The indications are described in details. So, if we want to understand the concept of the VT ablation, we have to understand also the mechanism of the VT ablation. We have mainly 2 mechanisms. The first mechanism is the re-entry tachycardia. For example, in patients with structural heart disease, for example, in ischemic heart disease, where we see endocardial substrate, usually in these patients, we have 2 kinds of tissues. We have healthy tissues and we have dead tissues. Healthy tissues and dead tissues are good. So it's not a problem. The problem is with tissues which are not very healthy and not very dead. So these tissues, they perform or they create a zone of slow conduction. And this zone of slow conduction can be the isthmus of the tachycardia circuit. And we have done a re-entry tachycardia using this zone of slow conduction. And this zone of slow conduction is our target for ablation. The other mechanisms is the focal tachycardia. So it's usually we have a focus, so a point which fires the whole time, and we just look for this point or this zone and we ablate it. So let's start with VT ablation in patients without structural heart disease. The most common localization for such VTs or PVCs is the outflow tract. In 70% of cases, it's the RVOT, and in 30% is other localizations like LVOT, epicard, aortic cuffs, his Purkinje, and papillary muscle. In the ECG, we see usually inferior axis and LBBB pattern. These patients have usually no structural heart disease. This VT is usually benign. It requires no ICD therapy, but in some cases, it could be an early form of right ventricular dysplasia. And in these cases, we see often polymorphic PVC, and cardiac MRI might be helpful because TTE, when we have an early form, we see in many cases no abnormalities. This is an example of a benign PVCs which came from the LVOT. We have here an activation map with the InSight system. We have here the colors of the rainbow, and we see here the red color, which indicates the earliest activation, and which was our target in this case to ablate. Now, the other group of the patients is the patients with structural heart disease. And when we say structural heart disease, we always have to differentiate. Is it ischemic heart disease or non-ischemic heart disease? It's very important for us to know that, because in ischemic heart disease, we expect to have an endocardial substrate. In non-ischemic heart disease, we expect more to find an epicardial substrate, which is definitely more difficult and more challenging for ablation. However, in these patients, we should not forget that the ICD implantation is recommended. So it's still the gold standard, and ablation therapy, even if it's successful, it does not replace the indication for ICD implantation. Recurrent monomorphic VTs in patients, especially with difficult antiarrhythmic therapy or with which is not tolerated, it has a very good level of indication in the new guidelines. Even in non-ischemic heart disease, it's a little bit less strong than in ischemic, but still strong, especially in incessant and therapy refractory VTs. Okay, so we use, of course, 3D mapping for the mapping and the ablation of VT. We have nowadays a lot of novel tools which make our life much easier. I will show you some of these tools which could be very helpful to use for VT ablations in general. For example, the integration of fluoroscopy in 3D mapping. Like in this case, we have two projects, RAO and LAO, and we don't have to use the X-ray all the time. Also, what very important, very helpful, is the vector guided mapping and ablation. This vector guided we have nowadays only in CARTO. new insight system also it will be also they will also use such a vector, but it's still in limited marketing release. And this vector is really very important. For example, for endocardial ablation, the vector should be like this. For epicardial ablation, it should be not like this. It should be, the vector should be guided in the other way, so that we have that we are ablating in the epicard and not in the other places. What we use for we use voltage map. For example, here in Carto, we gather a lot of points, and in every point we can. It's very important to in VT mapping to analyze the points which we collected, where we see the late potentials. If we are mapping during sinus rhythm or during RV stimulation, if we are mapping during VT, so an activation map, it's also very important to see these points, to see if we really see in this place mid-diastolic potentials. So don't believe always the system 100%. You have to see these points really with your eyes again. The voltage, what we use, what is recommended actually also, the voltage map for bipolar for in endocardial mapping is between 0.5 till 1.5. However, if we expect to find an epicardial substrate, so it's also very important to see the endocardial unipolar. In Carto, it's very easy to change from bipolar to unipolar. By unipolar, with the unipolar settings, we have the range between 3.5 till 5.5. And this is unipolar, but from endocardium. And in these patients, for example, we see also here epicardial bipolar map, and it's very comparable with the unipolar endocardial. However, the endocardial unipolar is not very sensitive, but it's always useful to try to see it, especially if we have no low voltage area in no low voltage bipolar area. So always try to see it, especially also in non-ischemic heart disease. What we also use is pace mapping. So, for example, you see here the clinical VT, and in this point we paced, and this is the paced ventricular morphology, and it looks the same. And this indicates a very good place to ablate. However, perfect pace mapping can be sometimes also not very precise, because it tells us not all the time about the place of the isthmus. It tells us sometimes only about the exit site of the VT circuit. Very important to look for late potentials in many patients. For example, in patients with hemodynamically unstable VT, it's not possible to make or to perform 3D mapping during VT. So it's unfortunately not, it's not impossible. So what we do, we perform the 3D mapping just during RV pacing or in sinus rhythm. And I would prefer RV pacing for many reasons. In the next presentation in 2 weeks, I will tell you why. Because I will tell you also more details about the mapping in ischemic heart disease. So what we see here, we look for such beautiful potentials, and we call it late potentials. However, if we are doing VT ablation, VT mapping, so activation map of the VT. For example, the VT is good tolerated, or maybe we use ECMO or impel system. I'm not a very good friend of using these systems to make activation map, also for some reasons. I will tell you also about that in the next presentation. However, if we are perform this kind of activation map, so we usually look for diastolic potential. So it means we really look on ECGs all the time, on EGNs, and not only on the beautiful 3D map what we are getting. How does the ablation look at the end? Usually, what we are doing an extended substrate modification. We look for all late potentials, and we try to eliminate them all. And this what you see here is not very rare. That's how VT ablation in ischemic heart disease look in most of cases. So in this slide, you see we summarize our approach for VT ablation in all patients. So if we have a sustained VT patient, the first question is, do we have here a structural heart disease or we don't have? If we don't have a structural heart disease, the next question, does it come from RVOT? If yes, then ablation therapy is the therapy of the first choice. If it comes from LVOT, epicard, or aortic cusp, or whatever, so ablation also is a good choice, but drug therapy should be also discussed. If we have patients with structural heart disease, so the next question, is it ischemic heart disease or non-ischemic? ICD is always the gold standard, and ablation therapy should be also discussed in both cases, but in ischemic heart disease, we should be really very generous with this indication. And now, let's talk about ventricular fibrillation. To be honest, when I've heard about the ablation of ventricular fibrillation for the first time, I couldn't understand anything. So this is why I would like to explain that just with a clinical case. So we have here a 20-year-old man with a VF storm, many episodes while sleeping, history of sudden death, 2011. He had ICD implantation 2011. We tried everything. We tried beta blocker, verapamil, ajmalin, amiodarone, without effect. Coronary angiogram was okay. TTE was also okay, no hypertrophy. MRI was not performed for logistic problems, to be honest. So our MRI didn't work that time. And that's what we've got in his ICD record. A lot of shots. And he has this ECG. The ECG without fantasy, it's okay. Yeah, we don't see much abnormalities. Ajmalin test was negative. And this is one ICD recording. So we see here normal beat, normal beat, normal beat, and then we see here PVC, PVC with R on T phenomenon. Another normal beat and another R on T phenomenon, and then we have this VF, and then shock. We performed Holter ECG, and we see here a lot of PVCs, and then VF and shock. This is Holter 12-lead ECG, and we've got this morphology. The problem is that every time he came to us, we didn't see. So at the time when he came to us, he didn't have any PVCs, and this 12-lead ECG was really very helpful to us. So we performed endocardial and epicardial pacemap, because to perform an activation map was not possible. We didn't find any low voltage area in his endocardium or in his epicardium. So what we've done pacemap, and the best pacemap was in epicardial, where we ablate here. And so now about 10 years after the ablation, and he didn't get these episodes anymore, due to the perfect pacemap in this case. So dear colleagues, I want to summarize. Catheter ablation is a highly effective method, especially in VT patients with ischemic heart disease. However, it doesn't replace the need to ICD therapy. It reduces the number of ICD shocks and improves the quality of life. We have such a problem with the ideal time for ablation. So the ideal time for ablation is still not clear. Should be performed after the first VT episode, or should we wait till the first ICD shock? However, at least after the first ICD shock, the catheter ablation should be discussed. And thank you for your attention.
Thank you very much, Dr. Noureddin, from Städtisch Kliniken Mönchengladbach.
Yes. ممتاز. المشافي الحكومية لمدينة جلادباخ الترجمة.
Gladbach, okay.